presentation. And, honestly, I didn't realize that this sort of series was ongoing. I looked through some of the videos and they're quite impressive. And kudos to you for doing this. I know it's a lot of work to put an event like this on regularly. And so I do definitely appreciate the opportunity. And, my impression when originally I was asked to give this was maybe not true. I think this is supposedly a very interactive conference, and so I have to apologize. This is maybe not as interactive as potentially could be, but I'm going to try to make it so. And I do have some cases at the end. So, there are going to be periods during this presentation where I'm unfortunately going to be presenting maybe a technique or so it can't be really interactive there. But towards the end, I have a few cases I think we could really discuss. And so if you can wait to the end, I think we could really certainly discuss things. So, I titled this "Nuances and Advancements in Non-Invasive Lateral Surgery," and maybe nuances are a bit of a misnomer. I'm going to explain sort of one of the tenets of lateral surgery. Here are my disclosures. And when it comes to minimally invasive surgery, I think everybody realizes that it's predicated on decreased exposure-related morbidity. It typically requires interbody fusion because of decreased exposure. There's really no muscle stripping involved for a true minimally invasive operation. So everything is muscle splitting. We're not stripping the muscle off the bone. So there's a much less degree of pain and bleeding that you would otherwise achieve with a traditional open approach. And there are a number of minimally invasive fusion procedures like PLIF. PLIF is much less common, although some still do it. There's a lateral, there's an anterior psoas oblique lateral, different nomenclature, but definitely essentially a similar approach to the interbody space, but from more of a retroperitoneal nature. And then we have the classic ALIF, which can be done as a mini open and now in the lateral position. So there are a variety of minimally invasive procedures. And again, all of these are predicated on a type of muscle splitting approach. Now, this is one of the nuances, or maybe not the correct term, but one of the tenets of laterals is the fact that it really is based on indirect decompression to achieve your improvement. Typically, these procedures are done for spondylolisthesis or deformity where there is an element of stenosis. And with restoration of disc height or reduction of spondy, which can fairly easily be done with a lateral approach, one does achieve an indirect decompression with symptomatic improvement. And one of the reasons why I like lateral so much more so now than I did previously, I was a big TLIF person, and that's by virtue of my training. Neurosurgeons are very comfortable with posterior-based operations, and we're basically taught we should always directly decompress, and that way we're sure we've done an adequate job. The problem with posterior approaches is often you have to destroy, and I'm going to use the term destroy, a lot of the normal anatomy to get to where the pathology is. So when you do a TLIF, for example, you end up taking the whole joint. And so you do lose an element of stability there. And you achieve it with screws in a cage placement. So you get back the stability, but in a sense, you've taken away, tissue or bone that didn't have to be removed. They were the innocent bystanders, and you're disturbing the normal anatomy. Whereas with the lateral, there's very little bony work, and you're just dealing with the disc, and you can restore the alignment and achieve the same outcome with less, quote, destruction, so less collateral damage. And so, I want to talk about that, and I also want to talk about another sort of tenet or well, you could call it a problem of minimally invasive procedures. And this is where technology, I think, brings a lot to the table, and it's the degree of radiation exposure. When I was in training and even early on as an attending, I didn't really think too much of it. Sometimes I would not even wear my thyroid shield or potentially even not really wear too much in the way of radiation protection for a short case. And that is a real problem. Radiation is a occupational hazard, and I think a lot of times, particularly when you're younger, you sort of underestimate the long-standing issues with it. And when it comes to a minimally invasive approach, you really don't see as much of the anatomy. So orientation is a real issue. So you see a small segment where you're working through, say, a tubular retractor, and without being able to visualize the surrounding anatomy, your trajectory or your localization can be off, and that's one of the problems with minimally invasive surgery. So you have to replace your eyes with a different sort of a guidance, and that's typically fluoroscopy. And so the degree of radiation exposure to the surgeon and staff in particular is markedly higher, and there's multiple studies that have shown that. And we talk about annual dosage limits, and we could stay within that with procedures, but there's such a thing as lifetime dosage. And I think I know a number of older surgeons who've potentially developed oncologic issues, and there are times that it's attributed to potentially radiation exposure. So if there's a way to minimize that and maintain your accuracy, I think that's important. And typically we are all aware of navigation, but that's been mostly used for screw-based techniques, and not really as well utilized for other aspects of the procedure. And I'm going to show how you can use technology to pretty much do the whole lateral procedure with very, very minimal radiation exposure, maintain accuracy and outcomes. And so that's the second part of my talk. So, and now proceeding to the cases. So this is a 61-year-old man with back and leg pain. Normal exam, so no neurologic deficit, but he's had pain for quite some time. He's had physical therapy and injections. So you look at this film, and I get X-rays on everybody, and he's got a spondy at L3-4 and a grade 1-2 borderline spondy at L4-5. So they often have an MRI with them, and this is the MRI. And you look at this, and you can see the spondy. It's a little less pronounced lying down. Often gravity will make the spondy a little bit worse. But you can see the problem here is a slippage, but also in the foramen. So the L3-4 frame is not too bad. Here's a nerve root and fat within the foramen. You can see the L4-5 frame and the exiting L4 nerve root, it's crushed here, right? So this is an up and down craniocaudal compression. So it's just from the slippage and loss of disc height. And you can see nerve is deformed, and this is the patient lying down. And you can imagine it's much worse when the patient stands. And so I think when it comes to what you're going to do about this problem, you have to kind of look at the structural problem. And so there's a slippage as well as the loss of disc height. And the other thing I want to point out is the ligament of flavum is buckling here. And so you also have a pseudodisc with the slippage. So you have compression anterior posteriorly here. And so not just foraminal compression, you also have central compression. So what are our treatment options? I mean, I suppose we could ask the audience, what would you do? I mean, there's so many ways to treat this problem.
Yeah, I think we should. Can we go back to that? Yeah, thanks, Paul. So we'll definitely ask the participants, see what they think and how they would tackle this patient with both back and leg pain. Is it neurogenic claudication, or is it more radicular on one side or the other, Paul?
It's a bilateral leg pain. I would say it's more claudication. As you know, sometimes it's mixed. The symptoms are definitely worse with standing and activity.
Okay. Yeah, we'll definitely have the participants put in their option here, either ALIF or TLIF or lateral, but we'll also try to get some of our faculty here to discuss. Nadir, what do you think? You see a lot of complex degen spine and the lumbar spine. What's your approach for these?
Yeah, I mean, a great case. And it's a very common pathology that we see. The question is, is it more back pain, more neurogenic claudications? The solution for the neurogenic claudication is easy. The question is where the back pain is coming from. Is it the spondy 3, 4, 4, 5, or is there a component of maybe facet arthropathy at L5, S1? But to me, looking at this, what I would probably offer the patient is a 2-level TLIF.
Right, so I can tell you the leg pain is predominant, and it's worse with activity.
Yeah, probably I would probably do a 2-level TLIF, 3 to 5, minimally invasively.
So anyone else? I think that's very reasonable. Honestly, like I would say like 10 years ago, I would do TLIF. TLIF was my workhorse. I did it in like 90% of cases, and occasionally some laterals and maybe occasionally some ALIFs. But TLIF was definitely my workhorse. But that was by virtue of my training. I wanted to directly decompress all these areas of stenosis. And but the problem is, like, you know, TLIF has its downsides, right? You know, in terms of the size of the cage you can place, the amount of, say, you know, we are all consider alignment an issue nowadays where we didn't 10 years ago. And I think I would argue with the TLIF, you don't get as much segmental lordosis per disc level. And, you know, often, you know, there's also risk of a thoracotomy, for example. I mean, it has its own complication profile. So, you know, so having said that, you know, so this is a very similar case with a spondy. And what I want to show is, like, you know, you could do an MIS TLIF. This is what I'm doing here. So I often do a unilateral approach for bilateral decompression because, again, I was always taught, you know, directly decompress, right? And so this is the post-op with a TLIF result. So it's very doable. So no problem. You can do a direct decompression. And so you can see this was a unilateral approach here through, I don't know if you see my mouse, but a unilateral approach, and it took down the contralateral ligamentum flavum here. Do you see my mouse or not? Pointer. Yeah. So you could take down a ligamentum flavum through, you know, from one side and get adequate decompression. But again, you know, there's a risk of a duotomy. It is somewhat time consuming as well to do this, but definitely doable. And again, what I did for multiple years. But lately, I've really come around to doing indirect decompression. And now it's reversed. I do at least as much laterals and ALIFs as I do TLIFs. And I'm going to explain why and the basis for that. And that is the fact that indirect decompression, I think, works in many cases. And the benefit is improved sagittal alignment. For me, that's a big plus. So the basis of the, indirect decompression is really disc space distraction. It results in increased foraminal height. Also improves lateral recess and central stenosis via essentially ligamental taxis. So that ligamentum flavum that buckles with the slippage or reduced disc height really causes a fair amount of stenosis. And and again, with the subluxation, you can realign the vertebral segments. That will improve your stenosis. And so this is that same patient. It came back 3 years later with an adjacent segment, you know, had a disc herniation here. You can see that. But 3 years later, we got an MRI, and you can see the indirect decompression. So, you know, with the laterals, you see the reduction of spondy. There's probably settled a little here, but the reduction of spondy at L4-5. But you can see the ligamentum flavum, that buckling is all gone. Right? And this patient had improvement in the leg symptoms, and you can see the foraminal stenosis as well here. So here's that nerve root crush here, that L4 nerve root, and you can see it right here. The nerve root is no longer deformed, and so you've decompressed it without any bony work. So this was all disc space work with percutaneous screw fixation. And so you're able to achieve it without much bone work, and I would argue less bleeding as well. And so I think it's a reasonable option. And there's a fair amount of literature to back this up. This is a paper way back in 2010. It's one of the first that looked at it. And it's by one of the, you know, you could call founders of laterals or the classic transpsoas technique. And it's Luis Pimenta. And he looked at 21 of his own patients. And these are all patients with lumbar stenosis, with spondylolisthesis or degenerative scoliosis. And what he showed was, or his group showed, that with laterals, you have increased disc height, foraminal height, and foraminal area, as well as central canal diameter. And this is not my patient, but from his study, and it just replicates what I just showed you for that case. You can see you can get central decompression, as well as foraminal decompression with placement of a lateral cage. And subsequent to this original article, or one of the first studies, there have been a number of studies looking at this. And this is a study published in Spine in 2015, so 5 years later, from a Japanese group, and they prospectively looked at 28 patients with 52 levels treated, and they looked at the cross-sectional area on MRI, as well as disc height and segmental disc angle, which, you know, again, these days, sagittal alignment is a big issue, and that's been one of the criticisms of TLIF is your degree of segmental lordosis that you can achieve is on a relative basis not anywhere near as high as what you can get with the lateral and ALIF. And so if you looked at his this group's study, you can see the cross-sectional area improved from a mean of 99.6 millimeters squared to 134. And the segmental disc angle increased from 3.5 to 7.9. Now, that's about 4.4 degrees, which doesn't sound much, but if you do that at, let's say, 3 or 4 levels, then you're doing about 15 or 20 degrees of improvement. And when you look at most TLIF studies, and now I'm not talking about if you go crazy with a TLIF, you do bilateral fascicectomies, put a huge cage in, do all this work, you can maybe get 5, 10 degrees a bit more, but your classic TLIF will not get you much in the way of any segmental improvement, typically a degree, if you look at the last studies. And this is again from their paper, and again, reiterating the fact that indirect decompression seems to work. One final paper I wanted to just bring up, and this has to do with more with spondylolisthesis, is from Juan Uribe's group, who's well known for lateral surgery. He had 16 patients, or actually 24 patients of grade 2 spondylolisthesis, 16 of which underwent laterals. And again, this is really non-comparable. He's looking at ALIF at L5S1 and laterals at the higher levels. But what you can take away from the study is that reduction occurs quite frequently, and these are higher, quote, higher grade spondies. And the degree of segmental lordosis, I would say, is a fair amount, 5.6 degrees per level. So, I've been sort of playing up the fact that indirect decompression works, but does it always work? And I'd be remiss if I advocated for a procedure without discussing some of the downsides of it, of the procedure itself. And I don't think it always works. There are certain cases where it wouldn't. If you go back to Pimenta's original study, 2 of the patients actually did not have as good of a result. And one was due to subsidence, which makes sense. You've lost your disc height restoration, and so that ligamentum is going to buckle again. And one, they just weren't able to get enough disc height, and I think they had some end plate issues with plated cages, so it doesn't always work. There's one other paper by Rob Isaac's group. And Rob used to be at Duke, but he's done a lot of laterals and a lot of work in this area. And what he showed was bony stenosis. So if you have bony lateral rhesus stenosis, it doesn't seem to work as well. And that also makes sense. If it's mostly a bone spur causing direct compression, distraction probably is not going to help that, because the ligamental tax is really not going to work. And the foraminal height restoration, probably not if you have like say a bony disc herniation or something compressive there. So those are 2 factors that need to consider when you're looking at laterals. But honestly, this would be a minority. In most cases, you're able to perform a lateral and get an equivalent result to a direct decompression, in my mind. And with a caveat, with the added ability to improve your segmental disc angle, I think it's a valid procedure that should be considered. So just a quick summary: indirect decompression, I think, is effective. It results in reduction in many cases. The segmental lordosis improvement is, I think, one of the biggest values, and it minimizes injury to native spinal structure. It really is less invasive. Not only is it muscle splitting, you don't do much bony work. And if you do it over multiple levels, you could actually improve, say, a flat back situation quite well. So if you have a patient coming in with multi-level disc height loss and a loss of lordosis, multiple laterals will achieve a more normal alignment without having to do something drastic like osteotomy. And obviously the risk profile differs. There's other risks with the lateral, but I'm trying to advocate for it. So I'll play up the fact that you don't have to worry about a duotomy so much. And so we need to be careful.
Sorry to interrupt. This is Ali. Oh, do you want to share your screen again?
Well, I didn't do anything. I must have lost it when you came in.
Oh, okay. Sorry about that. That's one of us must have. So question for you, which lateral, when you talk about lateral approach, what's your choice? Do you like to go trans-psoas or pre-psoas?
So that's a great question. It segues to my next portion of this talk. So this is a multi-portion or segment talk. And historically, I was a classic trans-psoas person, but now I do oblique approaches quite a bit, or anterior to psoas. If you I think OLIF is trademark, but anterior psoas or oblique trajectory approach, and it depends on the anatomy. I kind of gravitate to trans-psoas if it's feasible, but particularly at L4-5, it's not really feasible. And historically, you want to select the right patients. Look at X-rays and make sure the ilium is not high riding. But now that we have technology, and not only is it helpful for radiation exposure or reduction, it's actually helpful for like picking the right approach. You don't have to look at it beforehand so much, and I'll show you why. But you know, I do either approach, and I think if you will use technology, it'll make the procedure a lot easier. So there's a barrier for most people adopting lateral approaches because one, neurosurgeons in general aren't comfortable with anterior approaches, but number two, you know, with minimally invasive procedures, you don't really see their anatomy. So that's another barrier. So not only are you maybe not as comfortable as with an anterior approach, without being able to see all their anatomy, that's just an added barrier. And in my institution, with the use of navigation, that barrier has lowered, and everybody does it now in our institution. We all use navigation. So I'm just going to go over the technique, like it said. I have a short video that was made up by one of our residents. I want to go through, and then, you know, there's some cases at the end we could discuss.
Paul, quick question here from the audience from Michael Gilgano, who, by the way, is our guest next week, but we'll talk about that later. Michael asks, since you do both, or you've transitioned from trans-psoas to pre-psoas, what is, have you noticed the difference in your post-operative leg weakness or post-operative dysesthesias or you know, basically ipsilateral leg and thigh issues with the two approaches?
No, I mean, that's a great question. I think, you know, I'll tell you my own experience and then what I know of the literature. I think in my own experience, not much. I haven't noticed a huge difference. Now, knock on wood, I haven't had major nerve issues, and it may be for a variety of issues. I monitor all my patients, not just your standard stimulus evoked EMG. I also do motors. I do motor evoked on all laterals, so, and I test it pretty routinely. And if there's an issue, I move the retractor, and I'm just very careful. So I don't know if anyone or most people use motor evoked potentials, but I think it's actually more accurate. So that's one thing I do. The other is I don't actually break the table as much. So there's been some thought that breaking table heavily will stretch that nerve. So I just use a Jackson flat with a roll. And that, and I've been doing that for a long time. And the other issue is like, I don't use a fixed retractor. I think classically with the trans-psoas, you'd put a shim into a disc and the shim would be placed in the posterior disc space, and that would maintain a fixed position of the retractor. I actually use a table mounted retractor, but I don't put a shim or any other post in, so the retractor can move a little. So I just feel like with that, the nerve is never compressed for a long period of time, because how I put the retractor is just over the disc space, and there's a little psoas there. But I have a little separate retraction that can retract that little bit of psoas, and it moves around. So I don't think the nerve's under any as much tension because I don't have a retractor like really locked in place. But I haven't noticed a big difference. Now, if you look at the literature would suggest there is a difference. I think there was a systematic review or a meta-analysis that was published recently where they looked at it, and they just parsed through the literature. It seemed like the degree of nerve injury was much less with an oblique or anterior psoas approach. So, you know, so I wanted to describe this technique. So the advantages, I think, of navigated laterals, it's accurate, it minimizes radiation reduction, and so I don't wear lead. I don't wear lead for my laterals, which, you know, I think you don't, you know, from my past experience wearing lead, you're like drenched after the end of the case and you feel horrible. And if it's a longer case, you don't feel so good during the operation. And it tends to be time efficient in multi-level cases. I think you will be quick to wear laterals if you go on beyond 2 levels, for sure. And I'll explain why. So I'm just going to outline the technique very briefly. So the positioning, the reference frame placement, image acquisition, approach via navigation, discectomy, and the navigate cage placement. So as I alluded to earlier, I just used a Jackson flat table with just a roll underneath the patient. Now this opens up that area a reasonable amount, but it's not as much as if you're using a table and you're jackknifing the patient. And that's because that, you know, if a trans-psoas doesn't work here, I'll just do an oblique approach or anterior psoas approach. And it's easy to do this with navigation, you know, and I'll show you why. So the first step is to put your patient reference frame, and we're all familiar with navigation, so we need a reference frame attached to the patient. And depending on which levels I'm going to treat, if I'm going to treat all 3, 4, and above, I'll just put it in the anterior superior iliac spine. So let me orient you. This is the front of the patient right here. And the back is over here, and head is up here. So this is the anterior superior iliac spine. You can palpate this very easily during a lateral. And it's very easy to place this iliac pin. So I'll just place it right here. Now, if I'm doing 4-5, and if I have to potentially do an oblique approach, which would be putting an incision here, I can't have the frame here. So I'll put that more in the posterior superior iliac spine. So you can put it either way. So, you know, whatever level you're doing dictates where you can put this frame. And this is just a little harder to place because sometimes it's harder to palpate the PSIS. But so for orientation, this is the back of the patient. Here's cranial, and that's the front. So you can put the frame either way. Does not take very long, takes a few minutes. Then I drape sterilely. I just put another layer of drapes, and I'll bring in the intraoperative image acquisition unit. And you could use pre-op CT and register. We have intraoperative imaging, and I think most institutions have it now. Not a big deal. This takes literally 10 minutes from coming in, taking a spin. And one spin will allow you to do 4 levels. So I could do L1 to L5 with 1 spin. So I'm not bringing this thing in and out. So it's usually 1 spin for the whole case, up to 4 levels. And you know, people always wonder, do you not lose accuracy after putting your first cage in? So what I tend to do is, so the pin is in the iliac crest, either anterior or posterior. So I'll do the level, if I'm doing L1 to L5, I'll do L1-2 first because it's most distant from the frame. And what I've noticed is it doesn't change your accuracy very much after you're doing it. You place your cage, then you move to 2-3. It really doesn't change much. And you don't need some millimeter accuracy at all. You know, you may shift a couple millimeters here or there, but that's okay. Because we're just using this to place a cage in a very large disc space. So it's not that big of a deal. So one spin will get you 4 levels. You just start proximal and go lateral. I mean, proximal to distal. Now, this is the most important tool, if you ask me. It's a multi-function tool. It's a navigation pointer. It's a nerve stimulator. Here's a nerve stimulation point, and here's the clip stimulator. And it's your initial dilator. So I'm not using any fluoroscopy at all. So I'm not wearing lead. So the patient gets positioned, I put the pin in, we just spin, no fluoroscopy at all. So the fluoroscope's not even in the field. And so I'll use this at the skin level, and I'll project at the skin, and I want to be orthogonal to disc space if I'm doing classic transpsoas. And I'll mark if I'm doing one level, 1 inch, I'll center a 1 inch incision basically here. Okay. And so, you know, this is from the skin. So this is not a pointer in the patient, but from the skin, I'm projecting a point. And this is how I center the skin incision. So it's not based on fluoroscopy at all. And then you make your small incision, again, a very small incision there. You split the abdominal musculature. You can put your finger in, or a small narrow base retractor if you want to retract a perineum. And this dilator goes over it, you know, behind your finger. And you traverse a psoas under navigation. So it's not by fluoroscopy at all. So there's no fluoroscope. We're not wearing lead. And I will push this pointer. It's not really sharp, but it's pointy enough you can push it into the disc space, and that's your anchoring point. And so once it's in a disc space, again, it's being stimulated through the psoas here. And it's anchored there. And then you take the tracking frame off. Then you just sequentially dilate. You know, in this sequential dilation, you can stimulate. This is directional, so you can stimulate either way. And then you put your retractor in, and again, no fluoroscopy at all. And there's a host of navigated instruments now, navigated Cobb, navigated curettes, navigated, you know, cage inserter. This is, you know, you can use whatever system you want. This is just another company system, so you could interchange, it's agnostic. And, you know, so I do everything under fluoro now. I mean, not fluoro, but under navigation. You know, when I first started, I would periodically fluoro, or some, you know, just to be sure. But I've gotten to the point where I fluoro very, very infrequently for, you know, a standard case. Now, if it's a high deformity with a lot of collapse, I'll fluoro because navigation is not perfect. But for your standard, you know, degen, you don't really need to do much in terms of fluoroscopy. So so this is a standard lateral procedure now. It's all done in navigation now. So you have a fluoroscope in your field of view. You don't have to have the technical AP and lateral, which kind of gets annoying actually over time, and it's time consuming. Here's a rotate shaver. Again, this is navigated as well. Here's a navigated cage trial going in. This is a spiny case, as you can see here, adjacent segment disease. And here's a cage going in. And here's a pre and post op, and you can see this is put all under navigation. So you have desk height restoration, cage placement, it's very accurate. Now, I alluded to earlier, like if the iliac crest precludes a classic transpsoas approach, it's very easy on the skin, you can palpate the ileum. If it's in a way, I just bring the pointer more anteriorly, and I'll select a skin incision for an anterior sort of a oblique approach. And as you can see, this is a navigate dilator that I advance through the anteroborder psoas into disc space. It's oblique. In this case, it would be really hard to do just anterior psoas. The working channel is just not there. And at 4-5, it's sometimes like that. It covers the whole anterolateral border of the psoas, the disc segment. So you have to go to the anterior border. With navigation, it's so easy. So I'm not using fluoroscopy here at all. And it's the same steps. Navigate cage trial. Then once it's partway in, I will shift the shaft of the cage or the cage inserter dorsally to get orthogonal. Just your classic OLIF approach. And you can see this is anteriorly paid. I put the frame here in an oblique angle to work here. And here's just the cage in, and you can see it's orthogonal. So, and this was placed under navigation as well. So it works quite well. You can see the retractor is sort of an oblique trajectory. So, here's a quick video, and this was put together by one of our residents. They did a great job about it. And let me see if I can play it. And it's just another example of it, but I think video is very important to show you the process. And again, this is post-laminectomy sponding. So this patient had a lami, okay, something you see all the time. And it's got foraminal collapse. And you can see on M1, there's no spondy there, but when you stand the patient up, a good grade 1 spondy there. So this looked to be a symptomatic level. And a bigger patient, again, standard, Jackson flat with a roll. And a lot of taping. You can see it's a bigger patient, right? So 3/4, so I could put the frame anteriorly here. We'll make the incision, and I'm sorry, we didn't video the skin incision portion, or actually maybe we did. I don't recall so well. But so small incision there, and we're gonna go through the abdominal musculature and just, muscle splitting approach. Those are just 2 hemostats. The retroperitoneal space, you can see retroperitoneal fat there through the transversalis abdominis. And you can see your fingers there. You can see how small the incision is. The finger, basically it takes up the whole view. That's the navigate dilator going in with nerve stimulation. You can see we're traversing the psoas here, and then we're just going to advance it into disc space. Then we're just stimulating now. Once it's anchored, you just put each dilator and we just stimulate. It's a directional EMG. And here's the retractor going in. So very straightforward. There's no fluoroscopy at all. As you can see, there's no fluoroscope in the field. And this is an anchored dilator. You see it was in the disc space, and it actually guides you into the disc anyway. And so little residual psoas muscle, like I said, this is a classic transpsoas. So we just have a...
For your, sorry to interrupt, for your retractor, are you using a retractor that that anchors into the vertebral bodies, or you don't anchor the retractor itself?
Not at all. And so I found you don't really need to do it. This isn't anchored at all. You can see, now everybody can do this. This is just the discectomy component of it. It's a little bit sped up. Here's a rotate Schaefer going in. You could, actually Cobb going in here. Again, under navigation, we're not fluoroing at all. And I've come to this, I've developed a comfort level. I've been doing this about 5 years now, a little over 5 years. And so early on, I would fluoro just to be sure navigation wasn't leading me astray. And I would advocate, even when you're using navigation, if something doesn't look right, definitely fluoro, because navigation can be off. It's not perfect. I mean, I think it's it's highly reliable now, but it's not 100%. And so that's just a biologic going in. Here's a cage going in. It's a 22, I think there's a 22 wide cage, and I don't
Oh, a question for you, if you don't mind. So when you're using fluoro, I know this from personal experience, sometimes you unintentionally open the ALL. Sometimes you intentionally do it, but sometimes you unintentionally open the ALL, excuse me, and you can see on the X-ray the fish mouthing, and you know that you've entered the ALL. Has that ever happened to you? And if so, how do you determine that with navigation without fluoro?
Well, I think, well, like I said, fluoro's in the room. So if there's any concern or anything, and if you've released ALL, you can kind of know when you put the cage in, there's no resistance at all. But if I'm putting a cage in, there's not much resistance, I know there's something wrong. And so I'll bring the fluoro in. But I think if you are doing ALL release, having navigation actually helps you. You can put the pointer in front of the ALL, you can put the pointer next to the great vessels, and I think it's very helpful. As long as you have it's accurate, it'll actually help you know where you are in front of the disc space. So I think it's very valuable actually. You can't see everything sometimes when you're doing ALL release, and having a navigation there with three-dimensional imaging and being able to, you typically can see the aorta and the IVC. I mean, I honestly think it's safer in many ways. And sometimes I'll put the pointer in front, I'll advance it in front of the vessel. So it's between the vessels and the ALL. So it can be very helpful. Again, make sure it's accurate before you do that. But I mean, there's ways to check. And so, we wrote up our series here, and I'm not going to dwell on it. This was a while back, but it's just a fluoroscopy usage. And, we didn't do it for all the patients. I only started to keep track like later on, but you can see like the amount of fluoroscopy, 2 seconds, 2 seconds. I mean, not much at all. And that's just, in some of these cases are a little bit more, but they probably had a deformity or something else going on there. But for a standard case, you don't have to use much fluoroscopy at all. And I would argue nowadays, I probably use even less. The amount of reduction is quite significant. If you look at the literature about how much fluoro is used for like your typical lateral case, it's measured in minutes. So I think the amount of radiation reduction is significant. And again, I think it's an occupational hazard that you can avoid. And with multi-levels, I think it's more time efficient. So I've recently gone to navigate prone laterals. So I'll discuss this and we'll go on to a few cases that I think are a bit interesting, and it has to do with, quote, deformity. So here's a case of a 73-year-old man with L4-5 lumbar fusion, severe back and leg pain with numbness, right? And you can see the problem here just on x-rays. At the adjacent segment, he's coronally collapsed here. Some erosion of this vertebral body. And look at that, stenosis here. And the MRI looks pretty horrible with some of this instrumentation artifact. And so what do you do here? Well, there's a host of options. I guess it's like this other case. You could direct decompression, but I think it'd be hard to achieve even with a TLIF. It'd be a little bit of a pain. And you wouldn't probably get that much of disc height restoration with a small cage with that degree of collapse, if you ask me. So, I did a prone lateral here. So this is the patient. She's prone. So this is her back. And this is the flank here. And we're just using a pointer here to determine our flank incision. Again, this patient's prone. And you can see this is from the skin. It's just a projection. And we center an incision there. And this is just a navigated dilator. This is a different system. And the plus is the pointer, actually, the nerve stimulator. You're going to advance it into this collapsed disc, right? So we're completely orthogonal here, perpendicular to L3-4 in the midplane. And again, a host of navigated instruments. This is a small cop. It was so collapsed, it was hard to enter this disc space, so we had to sequentially distract here. But you can see the accuracy of navigation here in the prone position. In a bigger cob. And this is a cage trial. And this is the actual cage, expandable cage. And this is our fellow who's doing it. And you can see that, you have to be on a stool here. And this is a cage going in. So the cage is right in the midpoint here. And you can see here, the coronal collapse is the expandable cage. It's level now. And we were able to get disc height restoration here. And, we had to open, this is an open incision, but we put this in percutaneously, the top screw. And so we had disc height restoration. You can see the frame in here versus no frame in here. The foraminal stenosis was improved. And I didn't do a direct decompression of this patient. And so it's, here's just another case of that F4-5 now for a pseudo case. And I want to leave some time for talk, but this is a difficult patient to treat. I had a TLIF with an expandable cage, and it's pseudoed everywhere, and all screws are haloed, right? And you could try another TLIF on the other side, but I find that it's not ideal. You could try to put another TLIF cage here, but that's also not ideal. So again, this is where you could do simultaneous surgery. You could take out the instrumentation, and you could also do the pronal. Here's I'm just standing by here, but here's a resident, here's a fellow who's working simultaneously on both aspects of it. And so we were able to get, with navigation, these screws in different positions where their bone was pretty good. And then this was a prone lateral, and you can see the cage that we were able to place. And so like it's a viable alternative, and navigation is very helpful here. So, I'd be happy to answer any questions about the technique, and but there's a few cases that I think were interesting. Not so much the lateral aspect, but the presentation.
Yeah, I think it's a good time to see if any of our faculty has any questions. Jonathan, Nader, or Wendy, and maybe I'll ask one from the audience.
Great cases, Paul. I mean, truly, it's a big deal. Obviation of the use of fluoroscopy. It's a big deal. Lifetime exposure. And I agree. I have a few of people that I know, older people who developed cancers, and not too many, but a couple. And definitely, it's like I'm impressed. So I agree. Like when the question is, how much do you trust it? And maybe early on when you're learning and to use navigation for interbody fusion, you gotta maybe use the fluoroscopy too, just to confirm and get more comfortable, so that you can trust it more. But beautiful cases.
So I'm not advocating not using fluoroscopy per se, particularly early on. I think if they get comfortable, and there's always some nuances to using it. But I think once I think you understand how it works, it's like anything else. I think it can be very reliable, and I think actually helpful for cases. I think sometimes fluoroscopy can lead you astray, and having three-dimensional like imaging it actually can be helpful. But even deformity cases, I could show you a bunch of deformity cases where it's very helpful, because there's a rotational component with the deformity, and doing a lateral with a heavy degree of rotation can be a challenge.
So just one quick question from the audience. Although I will say that L4 screw, I don't know what Wendy thinks, but boy, that tip of that screw is pretty close to that calcified aorta, isn't it?
Well, it's definitely bicortical. But that was done on purpose. We needed some fixing. I didn't want to extend the fusion. Her discs are so good. If you had to go to L3, I was trying to stay within the same.
Yeah.
If you go back to her, I didn't want to go. She had such pristine discs above and below, and there's so much haloing. So I had to go for bicortical fixation.
Absolutely. That's a great looking X-ray. Quick question from let's see, from Dr. Abdul Shafi. How do you determine the proper cage height? Obviously, with experience, you can gauge that pretty quickly. But what's your recommendation for maybe some folks who are just starting or early in their practice with laterals?
Yeah. So the width and length navigation will help you immensely, honestly, because you can gauge the length and width very easily on navigation. This is if you look at this, it's 22 wide right here, and there's demarcations. Well, let me go to the trial. These are demarcations on the length, right? So the height is the only issue, and I think the height, it just depends on the situation. Early on I would like to say fluoro, but it's the tightness of fit. And you don't want to over distract typically, because I think that could lead to subsidence. So I'm usually, if I'm using static cage in probably the 10 millimeter height, if I'm trying to get lordosis, I'll use more of a 12 degree, 18 degree cage, and they have to be a little bit larger for the taper aspect of it, but it depends on the situation. So I do think experience plays a fairly heavy role, but if I'm going to be generic, about 10 millimeter height is sort of where I shoot for, because it's more anatomic. And also depends on the region of spine. 2-3 differs from, like, say, 4-5. So this has nothing to do with technique, but I think this is an interesting case. So this I don't have the blur, but this is a 54-year-old woman, okay, and she presents with back and leg pain, even leg pain, back and leg, even refractory conservative measures. Doesn't have a neurologic deficit at all. But here are X-rays. And I can tell you the MR, she's got grade 1 spondy with central stenosis. Okay, so the reason I bring this up is if you look at her alignment, her SPA is 11 centimeters. Her pelvic tilt is elevated. I don't have the numbers, and she does have a mismatch. Pelvic tilt mismatch is not horrible though. It's like, I would say borderline normal. But what do you do in these situations? I mean, what would you do? Anyone from the faculty or audience?
that was both equal back and leg pain, Paul?
Absolutely equal. Yeah.
Got it. Yeah, I mean, it definitely looks like she's got a pretty high PI there, don't you think? I think you need to.
I'm sorry, I don't have the numbers, but
Yeah.
she does. I mean, you can see that, you know, it doesn't project very well, but her PI is going to be in the 7-degree range.
And her MRI shows stenosis and listhesis just at that one level or multi-level?
One segment, yeah.
Yeah, I think I would, again, as we put in the chat, I mean, I would tackle this one level, probably, depending on how she is on supine films and how she reduces, probably a one level TLIF. What do the others think? Nader, what are your thoughts?
I mean, this is tricky because she has a high PI, and you want to maximize lordosis at that level. Otherwise, you know, it's just not gonna have a good outcome. So I think maybe this is a if you want to keep it at a single level, at lateral with big cage to maximize lordosis at that level. Would probably be the best choice, you know, but it's tricky. This is not an easy case given her high PI and you know, and her focal pathology. But yeah, I mean, these cases I don't like too much because you know the pathology is focal, but it all depends on maximizing lordosis at that specific level.
Yeah, so I find these challenging as well. I mean, you know, these days we are understanding more about the importance of sagittal alignment, and unfortunately, I think in some ways the sagittal alignment aspect gets pushed too much. We think about it more than maybe we should. So, you know, I bring this up because this type of patient with some of I've seen get T10 ileum, for example, because you know she's young, she's 54, I think. And so you don't age adjust, so SVA is 11 centimeters, not normal. So, you know, they get multi-level fusion operations, L2 ileum, you know, sometimes T10. I've seen this, believe it or not, for this problem. And, you know, the concern with a TLIF sometimes is you don't get that much, like say, lordosis, and maybe you fixate or segment in sort of mild kyphosis. So that's an issue, and I think it's a valid issue. Although there are very good surgeons who do TLIFs wonderfully, and they could get segmental lordosis. So I think some of it depends on your own experience and your technique level. But these are things that, you know, kind of go through your mind. What can you do? I think the issue a lot of times with scoliosis x-rays is patients sometimes will stand where they're more comfortable. So if you have someone with central stenosis in their claudicatory, they're going to be pitched forward a little. And I think everybody, you know, I know you guys understand this entity, but I think if you don't think about it, you just assume that it's a deformity, and it's not, you know, what I call a functional deformity, where patients just are comfortable in a pitch forward position. Now, some people argue, you know, how you could tell that by looking at their PT and whether they have a high PT or not, because they're not compensating. But I don't know if that's always true, because I've certainly seen patients like that. So some would argue if you just did a lamb here, they may correct themselves. I ended up doing a one-level operation. So I had more information. So her BMI is 38.6, so that's a factor too, right? For a one-level operation. And she's refractory to exam. She's not 54, she's 52, so I remembered wrong. But you can see she has a horrible degree of pain. And here's her MRI. Sorry, I forgot I had this. Apologize for that. But you can see central stenosis, grade 1 spotty. And what I wanted to point out is I just did a lateral here with perk screws, and you can see our alignment is pretty much normal. And so, you know, you can't underestimate a functional issue causing a problem. And, you know, I think just treating the one level is something to consider. You can always do a bigger whack later. So if I did this and she didn't correct enough, I could always do an L2 to ileum. I think people forget that sometimes, and they jump automatically to the bigger operation. So my point again, I'm sorry, you know, I should have realized I had the other fellows. I apologize for that. But you can see, like, you know, this is a minimally invasive operation, and, you know, laterals do well for it. Here's another case, and here's post-op. She got it a year later, but she had adjacent segment, or not an adjacent segment, but thoracolumbar disc herniation. I got an MRI, but you can see with indirect decompression, she did fine. So, and this is your follow-up at 1 year, so no pain. And so don't need a big operation, minimally invasive operation, you do fine. Here's another example. I think 57, issue of laminectomy. So, and she really can't ambulate, really can't stand. And here's her MRI in supine. Because she's got a grade 2 spondy here. With probably post-laminectomy spondy. Here's our standing scoliosis x-rays though. Now, would you do anything different? What would you do here? This is your best standing x-ray.
Yeah, I don't know, Paul. Your patients seem to be leaning forward a lot in the X-ray machine.
We asked them to stand as erect as they could, but this is just her.
And I think you made a great point about the functional deformity, and you're right. Some, not all standing scolio X-rays, they're not all going to give you the accurate picture. But that's why I do compare it to the supine, whether it's an MRI or a scout CT or even a supine X-ray. Because I think if, in the absence of any, multi-level disease, somebody could actually be, this quote unquote imbalanced from that severe stenosis, and this is their most comfortable position. I think this is probably a 1-level case, personally.
So I asked you that because she's had lamis from partial L3 down to sacrum. Okay. Supine, she's fine here, alignment-wise, right? I look at the supine a lot too, actually. And I'll look at I don't have the coronal supine, but I look at that too. I think it's very helpful. But so I wonder, would you do anything different with the, you can see her lami defects here. And it looks like she pitches forward right above it, or I mean to the side.
Let's see, we have some, as always, we have some phenomenal participants here. Michael, Dr. Selby, I know Dr. Yam is on as well. What would you guys all do for this previous multi-level laminectomy, but the slip is just at 4-5, correct? With that transitional level below?
Yeah, transitional level. You can call it 4-5 or 3-4, depending on how you call it.
So we'll give everybody a second to see what they'll answer. Nader, what's your thought on this?
Yeah, to be honest, I don't think there's a small fix for this one, in my opinion. You're going to do the math and calculate pelvic incidence and SVA and pelvic tilt, but like eyeballing it like this, looking at it, it's going to be at least, in my hands, L2 to pelvis, if not more. But you gotta do the math, and the TLIF at that slipped segment at the level below too. So if you want to call this the bottom level, L5, so you got to TLIF the L5S1 and then the slip segment.
Yeah, I consider the same thing, honestly. I looked at the scolio X-rays and I was going to do something bigger, but so the one thing I've come around to actually is the problem with the fusion or multi-level fusion. You can't walk that back at all. I say you bought the form. It could be a bad form. You could be sitting on I don't know, whatever. And the thing with a smaller operation of fusion is you could always do more. I've come around to that. So I decided to just do this, just a single level, really. And everything I think was functional because my reasoning was like, look, if it doesn't work, I'll just bring her back and do something like L2 to LEM or whatever, T10 to whatever. And I'm always struck by the fact, in a lot of cases, it's hard to tell because you get patients that stand up for scolio X-rays. Sometimes, no matter what you tell them, stand as erect as you can. Don't hold on to anything. And sometimes they have to hold on to something because they can't stand very well. It can be misleading. And that's the reason why I brought these two cases together. One's a little bit more extreme than the other is the fact that I think sometimes it's hard to know, no matter what you try to do. And it may be the better part of dollar to do something smaller to see if it positively impacts a person. And these are good, clear pictures. I have others that don't look so hot radiographically, but they still are doing okay. And so I think there's some value in doing something short segment. And if it doesn't work, honestly, I could convert this to L2 to LEM without too much trouble.
Well, that's a nice result. There was one, oh great, you have the 2-year post-op.
Yeah. Great cases, Paul. I mean, I can't agree with you more on the thought process. And plus, you know, you speak with the patient, you go with the risk benefit with each option. It's not only one option. It's on, you know, focal pathology. We can do a TLIF or a lateral, and then hopefully this would help. But the other option is a bigger surgery, longer recovery, and you gotta engage them in the thought process. Is that what you do, or you just give them one option and talk
Oh,
them
no,
into?
I do. I discuss it, actually. I go, we're going to do something limited or we're going to do something massive. To be honest with you, most patients are okay with a limited. Because, I'm pretty clear cut with a major deformity operation. Likely of a major complication in a 20-30% range. Likelihood of minor complication, much higher. Likelihood of any complication, you're almost, minor is like a UTI or something. I'm very clear cut with them that, there's a high risk of a complication. Then we say, well, we're going to try something smaller. Most patients are all for it, actually. And they understand we may have to do something bigger, and I've done that in the past. So I give you these two examples, but sometimes a small operation doesn't work, and you have to bring them back. But I think the problem is if you start with a big one, you can't walk that back. And, PJK is the bane of deformity surgery, if you ask me. And sometimes you start going from T10 to T4 to C4 to, and you just can't win. And that's a real issue.
Paul, thank you so much. In the last couple of minutes, we're going to put you on the spot a little bit here. You're a colleague and a friend and obviously a terrific surgeon. Can you share with us, how many times you've had to either abort a lateral or a significant, significant complication that made you, think twice about the case, ureter injury, bowel, vascular stuff, all the horrendous stuff that we hear. Can you just share with us maybe your take on that and whether you've encountered that or not, and how do you kind of cope with that and continue to doing these procedures?
Yeah, so I'm not the type of surgeon to actually proceed with a case if it just doesn't look right. Maybe I'm a scared surgeon in some way. So I've not had a bowel injury. I think I've come close to it because I've seen the perineum and it's been underneath my retractor, but it didn't turn out to be a bowel injury. But that's always a risk, bowel. So sometimes you're transperineal. When you do your approach, you want to stay retroperitoneal, but for whatever reason, maybe you catch part of it with your dilator, and you see some pinkish tissue at the bottom. So that is certainly a risk. I've not had a perf, but it's certainly a risk. A vascular injury is like the worst case scenario. People die from that. And so, I look at MRIs all the time. So if the vasculature, particularly at 4-5, like if it's an early bifurcation and the iliac vessels are in the anterior lateral border, I'm not going to do no lift. I'm not going to come close to it. And if the iliac crest is high, I'm not going to even try it. So I actually I look at MRIs quite a bit, cross-sectional MRIs. And at 045, if there's an anterior psoas sign, if the anterior psoas is pulled forward, I'm also not going to do a lateral. I'll do a T-lift there. So I think it's very important to look at your cross-sectional MRI and pay attention to things beyond the nerves. The psoas, the vasculature, it's very important because I don't want a vascular injury and I don't want a nerve injury as well. So it's like anything else with the neurosurgery, preparation is very important. Looking at your anatomy, not just the nerves, but the surrounding anatomy. So those are all things that I think you need to consider heavily when you're doing this approach. But I've had problems. I've unintentionally ruptured AOL and a cage migrate anteriorly. I've had nerves crossing the field, and I'm not the type to fiddle with it. If I see a nerve, I'm aborting, I'm doing a T-lift. I've done that, I could think of 3 times where the nerve was too close and I didn't want to deal with it. And I just backed down and we did a posterior operation. So I think, all surgeons are a bit different. I think if you pay attention to anatomy and you try to be a safe surgeon, you can minimize risk. But having said that, if you operate, you're going to get a complication. The old adage is it's like death and taxes. It's always going to happen, right? So if you operate enough, you're going to get a complication. And until you're not having a complication, they're either not operating or they're lying. I think it's one or the other. It's one of these things where I think you just try to take care of the patient as best you can.
Those are certainly words of wisdom. Well, we're going to stop right on the hour here. We would like to stay on time. Thank you so much, Paul, on behalf of our group, our faculty co-hosts, and the participants. This was really an excellent topic. It's always a hot topic. I'm sure we'll talk again about lateral surgery in the near future. So thank you on behalf of everyone. Dr. Shin is not with us today, but he will be hosting next week. And our guest will be Dr. Michael Galgano from upstate New York, phenomenal spinal neurosurgeon who's an expert in both deformity and oncology. So be on the lookout for the flyer for next week. Thank you, everyone. Nader, Wendy, and Aaron, and Jonathan, thank you all for joining us today. And we'll see you all next week. Thank you, Paul.
All right. Thank you very much. Appreciate it. Bye.